I think we will move now to the last talk of the first session. So it will be on the burden of AML, mutation and prognostication implications. This is still a satellite talk and will be given by Dr. Naval Devar. Dr. Devar is Associate Professor of Hematology at MD Anderson Cancer Center. He has more than 200 publications. He's a director of Leukemia Research Alliance program. It's a privilege to have you, Dr. Devar, with us. If you kindly unmute.
Okay, can you all hear me now?
Yes, thank you.
All right, great, thank you. Sorry, I don't know what happened. I reloaded the page and it is working. So yeah, it's a pleasure to speak to you all here. I'm going to be speaking about the mutations and prognostic implications in acute myeloid leukemia. I work at the MD Anderson Cancer Center in Houston, Texas, and I focus on AML clinical trial development. This is a Astellas satellite symposium. The opinions here are my own opinions and experiences. These are my disclosures from research funding as well as advisory and consultancy. And there may be some comments on any medications that may not be approved. So when we think about acute myeloid leukemia, I think it's important to look at the average age of diagnosis of patients. So the average age of the AML patient is 69 years. And as you can see, the majority of patients are older patients. Well, about 70% of patients are above 50 years of age. And that is important because we also see that the survival of patients comes down as they become older. And this is because of a variety of factors. Older patients, they tend to have more adverse cytogenetics. Frequently, they are more frail. They cannot tolerate intensive chemotherapy. There may be other issues related to drug sensitivity in this population. So this has been a major challenge for acute myeloid leukemia therapy development, is how can we improve outcomes in the most common group of patients, which is the patients above 60 and 65 years. So one of the major steps forward in the treatment of AML has been the emergence of extensive molecular annotations and sequencing. And here you can see that we now know the most common mutations that are seen across AML, and these include NPM1, FLT3, IDH1/2, and then other ones that may not be as common but are very important, like TP53. And on the right-hand side, you can see how prognostically important these mutations are. So historically, 15, 20 years ago, we used to say patients are intermediate cytogenetics, but that included almost 2/3 of the patients. Now we see that when we incorporate the molecular information into that intermediate cytogenetic population, you can actually prognostically stratify it into much more detail. And there can be some patients who will be intermediate or diploid cytogenetics who could have very favorable outcomes, like the NPM1 mutated FLT3 wild type. And then there can be some who would also be intermediate diploid cytogenetics, but can have. Can you hear me?
Yes.
Okay.
Yes, I can hear you.
Okay, thanks. Yeah, who could have very adverse outcomes, such as patients with TP53 mutations, who even if they're diploid, can do very, very poorly. So I think it's very important to use molecular information in frontline, both in prognostication, also for treatment selection, because we have targeted therapies as well as antibodies that work in particular subsets, and potentially for transplant decision making as well. So this has led to the recent version of the ELN, the ELN 2017. There will be a more updated version coming out soon as well. And in the ELN 2017, you do see that we now have incorporation of the most important and common molecular mutations. This includes FLT3, NPM1, CEBPA, as well as mutations that independently will predict a adverse outcome in spite of having normal or diploid cytogenetics. These include TP53, RUNX1, ASXL1. The other thing that we're starting to realize is that individual mutations may not be sufficient to give the full prognostic picture. For example, if a patient emails me or a physician emails me and says, I have a FLT3 mutation, what is my prognosis and therapy? I cannot give an answer because, as you see, FLT3 can be in favorable, intermediate, adverse. What I really need to know are two things. what is the FLT3 allelic ratio or allelic burden, and what is the co-occurrence of NPM1. And so just knowing one mutation is not sufficient, and you will see, I think, over the next 5 to 10 years, new iterations of the ELN NCCN that will start incorporating mutational combinations and the impact of one mutation on the other, as well as the actual burden of mutation, not just qualitatively is it positive, negative, but actually how much mutation is present. All of this, as I mentioned, has significant prognostic value. And as you can see here, AML is not one group. So when you see a patient with AML and they say, doctor, what is my prognosis? There's not one answer. Obviously, you can see from this slide, it could be 95% in patients who have APL, 80 to 85% in core binding. And then you can go all the way to the complex karyotype with TP53 who have less than 5% survival at 4 to 5 years. So the prognostic in mutation and cytogenetics is very critical upfront for understanding the outcomes, but also for developing therapy, because a particular therapy that may have a marginal benefit in a favorable group could be very, very effective in certain high-risk groups. And these include new emerging therapies, including TP53 targeting drugs, CD47 antibodies, and others, and MLL rearrangement targeting drugs like menin inhibitors. So it is very important to know the baseline prognosis, both for the patient and for treatment. I'm sorry about the formatting. I think we put this from my template to the other template, and that's causing some issues. But hopefully you can see molecular studies also have therapeutic implication beyond prognosis. And this includes at least 4 major groups for which we have either approved drugs or emerging drugs. FLT3, the first one, the most important, the most common. And for the last 12 years, many different FLT3 inhibitors have gone through trials and are now getting approved across the world. IDH1 and 2, more recent story in the US, we do have IDH inhibitors now approved in relapse, as well as some data emerging in frontline. And then recently now there are NPM1 and MLL rearrangement targeting drugs. Very exciting, a group of drugs called menin inhibitors. There are 2 in clinic and 2, 3 more coming very, very quickly. And from the initial data, we are very, very excited and think this could be another major breakthrough in targeted therapy after FLT3 IDH. And then for TP53, we are still looking, but there are now a couple of approaches using immune therapy, CD47 antibodies, and potentially APR that may work here. So we really are moving into a very targeted, selective approach for AML, not just one broad treatment. So unfortunately, this slide looks like it was a lot of the information was lost in formatting. But the bottom line is that in AML treatment, we have seen accelerated progress. And actually, in the last 3 years in the United States, we have had 9 new drug approvals. This is quite fantastic, because for the previous 30 years put together, we really did not have any major drug approved. So this is now, of course, happening in the rest of the world. Those drugs are being approved. And now the challenge is how we use them optimally, how we mitigate toxicities, and really, to me personally and at MD Anderson, how we combine them optimally, either sequentially or in an MRD setting to really improve the outcome, something that you have heard a lot from the ALL colleagues in the previous talks. And I think we now have tools like this for AML that we have to optimize. So talking about FLT3 mutation, as I mentioned, is the most common. About 30% of patients will have a FLT3, either ITD or TKD mutation. The ITD is the most common among the two. And as you can see in this paper that was published almost 20 years ago now, the first one to show the impact of FLT3 on outcome, you can see that people who have a FLT3 mutation have a very adverse outcome. 5-year survival in ITD mutated was about 25%. Now, since this is, the drug is not yet approved, I won't be talking about therapeutic outcomes, but there's a lot of published data out there from many colleagues across the country, as well as from us at MD Anderson, showing how this has changed dramatically by using upfront therapy, integrating FLT3 inhibitors, where we're now reporting in publications and presentations 4 and 5-year survivals of 65 to 75%, starting at 25%. So no doubt in our mind, the identification of FLT3 and the incorporation of FLT3 inhibitors has changed the face of this disease dramatically, and will continue as we move from first-generation FLT3 inhibitors that are currently available to second and third generation that are going through frontline trials in combination with chemo. The other thing with FLT3 inhibitors and FLT3 mutations is that, again, it is not yes and no. You can have a FLT3 mutation positive patient who may have a very low allelic burden, and the prognostic impact of that mutation may be limited to none. And you can have others who have very high allelic burden where the FLT3 is the primary driver of the outcome. And so every quartile increase in FLT3 that was nicely shown in this paper by the Spanish group impacted the response as well as the survival and event-free survival. Here, looking at the impact of co-mutations, what is seen is, unfortunately, again, the formatting has been affected in the transfer. But basically, we do know that co-mutations can impact the outcome of FLT3. And what we see is that people who have a TET2 mutation, people who have a DNMT3A mutation or trisomy 8, they are in the black curve. So even if they have a FLT3, but the co-mutations make it much worse. On the other hand, those who are FLT3 with a NPM1 and a low allelic burden FLT3 and none of the co-occurring adverse mutations I mentioned can actually do quite well. This is looking at the impact of the ITD burden and cytogenetics. So cytogenetics still has a prognostic value. People who have poor risk cytogenetics with the FLT3 can do quite poorly, whereas those who have FLT3 and have favorable good risk cytogenetics here in the purple curve can do quite well. So now looking at the therapeutic approach in general, not focusing on any specific drugs. Historically, the goals of therapy for younger, fitter AML, and they continue today, not just historically, have been to try to cure patients, right? And that's the unique thing about acute myeloid leukemia compared to many, many solid tumors. It's a kind of binary. Either you achieve a remission and you achieve long-term 5-year survival, or you end up with high toxicity and potentially early mortality and toxicities. And so the goal with younger patients is still intensive induction, anthracycline cytarabine based. There are many variations of this that I will not go into, but in our experience at Anderson, using pure analog based approach such as FLAG-IDA regimens have shown good efficacy. And then once in remission, we decide transplant or no transplant based on their baseline molecular cytogenetics. I will say the majority of our patients, we still lean towards transplant at this time, which remains a curative option. And we are seeing about 50 to 60%, in fact, in our most recent analysis, about 65% 5-year survival. I think Dr. Kantarjan is speaking in a couple of hours, and he will show you some of our update analysis. So we are making progress in younger AML. Older AML, not as clear yet. I think we are making progress, but we are still far away from where we would like to be. The 5-year survivals till 2015 were about 10% or less. Now with the advent of new drugs, FLT3 inhibitors, BCL2 inhibitors, IDH, we're getting to 30, 35%, but still need to improve this quite significantly. So the traditional approach to AML therapy has been two things, because that's all we had. Either you get intensive induction chemotherapy, such as 7+3 anthracycline cytarabine or FLAG-IDA or CLIA-based, and then we go to transplant for majority of patients after they achieve remission. For the unfit, the options were hypomethylating agent, decitabine, azacitidine sort of therapy, or supportive care, or clinical trial. So this was very limited selection that we had available. Now, this has changed quite dramatically. This was a recent paper that we published in Blood Cancer Journal with colleagues across the US and Europe. And you can see that there is a major shift, at least in US and in some regions, Australia, Europe, where drugs have become available, to using molecular information and cytogenetics to select therapy. And for patients who are young and fit for intensive therapy, we absolutely are looking right in the beginning to see if they have core binding factor AML, in which case we would add CD33 antibodies like gemtuzumab to the induction therapy. FLT3, we would add a FLT3 inhibitor. For patients who have therapy-related AML or AML with MDS-related cytogenetic changes, secondary AML, we would add CPX351-like drugs. And for the others, we would use intensive therapy. And there are now investigations looking at adding venetoclax to intensive therapy, which is showing very, very exciting early activity in frontline and relapse. Similar thing for the older AML, but now HMA-VEN is kind of the backbone, but can we improve that further by adding targeted therapies? And these are in trials. And for TP53, for the first time, we hope that we have a couple of approaches through immune targeting CD47 macrophage activation and potentially through other drugs like APR. But to get to this, what I showed you, to select these therapies, you really need that information. And this is now the big battle in many areas, how to quickly, because we know time is of essence. We cannot wait 21 days or 28 days like solid tumor to get molecular profiling information. So how can we get that data? And this is kind of the schema that many places are using. This is what we do at Anderson. We get quickly the bone marrow flow cytometry. We get the cytogenetics FISH, especially core binding factor and MDS related cytogenetic changes FISH very quickly, usually 48 hours. So this helps us know if this patient has APL, core binding factor, or potential candidate for CPX351. And then we rush what we call a rapid molecular panel, 8 or 9 genes, FLT3, IDH, TP53, NPM1, CBPA, and then we proceed with therapy around day 5 or 7. And then we get a bigger panels coming in later, but that is for research, including other mutations, ASXL1, GATA2, RUNX1, etc. So the question is, how can one wait? This was a very nice analysis that was done by the German cooperative group, Dr. Rohlig and others, to say if you have a patient and if you waited 5 days or up to 10 days or up to 15 days, would that impact your outcome? Meaning, can you wait or should you just start therapy and then figure out what to do with mutation and cytogenetic information later? And what they showed was quite interesting, that even waiting between less than 5 days, 5 to 10 days, and up to even 10 to 15 days, although I think that is a little bit debatable, was not associated with adverse outcomes. They looked at 3 main features: early mortality, which is 60-day mortality, CR rates, and survival. Now, one has to be careful with this data a little bit because this was done in the setting of a cooperative group clinical trial. So these were all patients who could make it onto the trial. And we know we have a lot of patients who come in very sick, crashing and burning. And so, of course, you have to make individualized decision. But for the majority, 85, 90% of patients, where you can watch them closely, inpatient or outpatient, you can see that they're not highly proliferative, it is better to get molecular cytogenetic information and get the right selection up front rather than rushing to therapy. What about for patients who are fit for intensive therapy? We discussed this already a little bit. The selection is usually based on cytogenetics, whether they're core binding factor inversion 16821, or have therapy-related AML or AML with MDS-related cytogenetics, or a FLT3 mutation. And for others, we do the traditional induction with the addition in our center at this time on a trial of the venetoclax in the frontline setting. So this is our treatment algorithm that we published in a recent review of frontline patients who are FLT3 mutated, where we're doing the intensive chemo backbone with FLT3 inhibitor for induction, and then continuing that for consolidation. We prefer the second generation FLT3 inhibitors with induction in this scenario, although those are not yet approved in the frontline setting in the US, but this is done in the trial setting. And then the next question is, can we get the patient to transplant or not? In general, our approach and the data that we have published and others have published suggests that FLT3 in general should be considered for transplant. There is a debate in the low FLT3 NPM1 mutated, but we actually just did a recent analysis that will be at the EHA, showing that even in patients with very low FLT3 ITD, less than 0.1, who have a co-occurring NPM1, in fact, transplant still had a benefit. Those patients actually do quite well on their own, 60, 70%, but with transplant, we were able to get more than 90% alive at 3 years plus. So in our opinion, I think transplant still remains the goal for these patients who have a FLT3 mutation. And then, of course, post-transplant maintenance, as you may have heard, there are many trials showing benefit, and we do use a FLT3 inhibitor post-transplant for maintenance. We can skip this. We've already discussed this information. What about the role of transplant? And I think this was one of the seminal papers by Dr. Schlenk in the German group, showing that in FLT3 mutated patients, if you look at the right-hand curve, that the addition of transplant, that's the donor curve, did improve outcomes, but you can see the improvement was not complete, went from 20% to 35, 40%. Now with the incorporation of FLT3 inhibitors, transplant, post-transplant maintenance, we and others have started reporting up to 75% 3 and 5 year survival. So I think it's not one intervention, it's multiple interventions that are required. This was a paper we published, a review on ongoing FLT3 inhibitors trials, approvals, next steps, combinations. And it's important to note that all FLT3 inhibitors also are not one. There are different approaches. Some target type 1, some target type 2. This is important because the type 1 inhibitors can target both the ITD and the TKD. So they have an advantage where they can cover both types of mutations. The type 2 inhibitors are very, very potent, for example, quizartinib, but we can see escape through the acquisition of on-target TKD mutations. So one has to be aware of that. But I personally think both of these will have roles, and we actually have data using them in different salvage settings, and we often find that one may overcome the resistance that is seen with the other. What about the unfit AML, patients who are not suitable for intensive chemotherapy? This is a scoring system that Dr. Kantarjan from our group published many years ago that continues to be used. There are variations of this that have been used by Fred Hutch and published and other groups. And what you see is that when you use these factors, and there's an online scoring system, one can easily go on Google and just say online intensive chemotherapy mortality score. You will see this, and it will give you a predicted induction mortality. Many of us do this when we see the patient. Okay, he looks frail. Okay, he looks good. And many times I think if you have good experience in a major center, you're probably correct. But if one wanted to be objective, this will tell you the predicted induction mortality based on analysis of 1,200 patients at MD Anderson. This is again, discussing the fact of the improvement we're seeing in the younger patients over the last decade. In fact, the most recent curves are now looking at close to about 65% at 3 to 4 years. And in the older patients, unfortunately, not much progress. But again, in the most recent era, 2015 to 20, we are starting to see a improvement at about 30-35%, 3 to 4 year survival. This is predominantly with the BCL2 inhibitor being added, and we hope, and this is what I'm showing here, that we're starting to see now maybe an improvement, although the follow-up is short. So we have to wait and see in time. FLT3, the other important thing to note is that the frequency of this mutation is much less common in older. So as you can see, pediatric groups, it's uncommon. Then it peaks in the 20 to 40, 50 population, and then it drops. So we do a lot of trials in older FLT3 mutated, but it is challenging to find these patients. And we still are not sure what is the best approach. Aza-Ven is approved in the US for this population, but as you may know, the survival is only around 11 to 12 months in the FLT3 mutated. So can you add a FLT3 inhibitor, do a triplet? Can you do a sequential approach? What is the best way? We are looking at that at this time and trying to find the optimal path. This is our current approach. Again, at MD Anderson, we do have frontline combinations of azacitidine HMA with BCL2 inhibitor with second generation FLT3 inhibitors that are ongoing in the triplet setting. And we've shown some of the data at the ASH meeting last year, and we'll be updating at EHA. And I would say very, very promising remission and molecular and MRD clearance, but we do see myelosuppression. Luckily, the early mortality is still 0, but one has to be very familiar. But I do think this is the way we will be going in the future, similar to myeloma, where we combine drugs in the frontline setting with optimization for myelosuppression and toxicities. And I think it's very important, even in relapse setting, to realize that the escape clones are usually driven by one or more major mutations. And in relapse refractory setting, it is very important to try and identify a targetable mutation. That is really the only true chance your patient will have of getting into a remission. We looked at this in the FLT3 inhibitor field, and actually very interesting data that was presented by Dr. Alotaibi from Saudi, who was a fellow here, who has now gone back there and is working with your group. He did an excellent analysis that was published in the Blood Cancer Discovery, looking at the secondary resistance patterns in patients who received different FLT3 inhibitor-based therapies and trying to understand what happens after you get a FLT3 inhibitor and drives the resistance. And what we found, and again, I apologize because somehow the formatting was messed up in this transfer, but we looked at a big number, almost 1,000 patients, and we found 70 patients who responded to a FLT3 inhibitor and relapse, and then had a molecular full sequencing at baseline and relapse. That was hard to find, but we found about 70 such patients. And then we had a cohort of 100 patients who were primary resistance, meaning that they just didn't respond, but we had the NGS profiling done at the baseline. So the key findings are quite interesting, that FLT3 mutation is actually lost in about 1/4 of the patients. So you have a patient, FLT3 mutation, you give them FLT3 inhibitor, they relapse 6 months, a year later, and you will see that 25 to 30% will no longer have a detectable FLT3. This has been published by others as well. So it's important to check FLT3 at the time of relapse, because you may not have a FLT3 mutation, then you don't want to give a FLT3 inhibitor. And the opposite is true too. We have published many years ago that about 20% of people who did not have a FLT3 at baseline could acquire a FLT3 at relapse. So the point is, you need to check FLT3 again at relapse before deciding a therapy. There may be people who acquired a FLT3 who didn't have it before. There may be people who had a FLT3 before who have lost it. The other thing we saw is that when you use type 1 FLT3 inhibitors, you don't see D835 mutations. 0 patients had D835 escape. On the other hand, with the type 2, you can see these as escape mutations in about 30%. So there may be a benefit of type 1 FLT3 inhibitors. There are other pathways that cause resistance, though, in the type 1 inhibitors. So it's not that they don't get resistance, it's just different. It's off-target parallel pro-survival pathways, such as the MAP kinase RAS, that causes resistance. So one has to look at those, and we have started working on developing MAP kinase RAS inhibitors to overcome that mutational escape. The other thing we saw is that patients who had a loss of the FLT3 at relapse actually do better. So, it is probably the fact that the FLT3 inhibitor was able to get rid of the FLT3 clone. So even though that patient relapsed, they relapsed with a less proliferative, less aggressive clone and could have a better outcome, as you can see. So again, important to check the FLT3 at relapse, may have both therapeutic and prognostic impact. And the other thing we saw is that any emergent mutations that were driving resistance, such as the FLT3 TKD or the RAS MAP kinase, could drive a worse outcome. Again, not too much we can do for some of these, like the RAS MAP kinase today. Of course, for the D835, you can use type 1 FLT3 inhibitors. So in conclusion, what we saw in this analysis, which is now published and available, is that it is very important to check FLT3 at relapse. Some people lose it, about 30%, others may gain it. Type 1 inhibitors may have an advantage that they cover the ITD and TKD, especially when they're combined up front with chemo or HMA with ongoing trials. This may be very, very beneficial, but they do have their own mechanisms of resistance and escape, usually through the emergent mutations in the RAS MAP kinase pathways. And again, we think that this was all with single agent or low dose chemo combo, and hopefully with venetoclax combinations with FLT3 or intensive chemo with FLT3, we will be able to overcome this. This was a paper we had published a few years ago in Blood, again showing that FLT3 is a very, very complicated pathway. It's not a straightforward just using FLT3 inhibitor. This really shows why we need combinations. There are multiple parallel pro-survival aspects that are involved, activation of mTOR, RAS, STAT5, bone marrow microenvironment, CXCR4. And so I think we need to keep developing novel combos in multiple FLT3 inhibitors, just like we have multiple TKIs in CML. And with that, I will stop. Thank you very much. Please feel free to contact me anytime for any acute leukemia-related questions. Thank you.
Thank you, Professor Daver, for an excellent talk. Due to the time, I think we will ask the attendees. So we have now more than 3,100. If you have any question, just email Dr. Daver, and I will kindly ask him to answer as much as he can.
Absolutely.
And,
thank you.